Welcome, and thank you for joining us this afternoon. My name is Lee Lowry, and I'm the Executive Director of the American School Health Association. Thank you for joining ASHA for today's webinar, You Are the Key to Cancer Prevention. Before we get started, I'd like to share a little bit about ASHA. ASHA is the only organization that addresses multiple disciplines in school health and that is devoted solely to school health. Our membership of approximately 700 individuals represents school health as administrators at the local, state, and national levels, as health and educational professionals in a pre-K through 12 school setting, and as academics conducting research that informs and prepares school health professionals. We're also the proud publishers of the Journal of School Health, a premier journal in the area of school and adolescent health. Members of ASHA can elect to receive a hard copy or an electronic copy of our journal. Our membership fee is inexpensive and provides you access to the journal and also to our biweekly e-newsletter, School Health Action, as well as free continuing education hours through approved webinars like today's and through CE qualifying JOSH articles. If you haven't already, please consider joining, volunteering, and becoming a member of the ASHA community. Visit us at ashaweb.org to learn more. Our 2017 conference will be held this October 11th to the 13th in St. Louis, Missouri. Please join us to meet, share, and inspire ideas and conversation with like-minded school health professionals. 4 interdisciplinary-based tracks are offered during our conference, including administration, coordination, and leadership, programs and services, research and emerging issues, and teaching and learning. Our conference registration is now open, and early bird rates end August 24th. So be sure to visit our conference page to learn more about our oral sessions, posters, and roundtables, along with our pre-conferences and a full-day skills-based post-conference session that we'll be offering. As I mentioned, the continuing education credit for today's webinar is free for all of our members. If you're a non-member and you'd like to receive CE credit for this webinar, the cost is $30. After the webinar, you can receive 1 Category 1 CE/CH for MCHES and CHES, 1 contact hour for continuing nursing education, or a certificate of attendance based on 70% or more participation today. Participation is measured by the amount of time the webinar remains active on your screen. We'll provide details for obtaining CE in a post-webinar email that will go out in the next few days. Before I introduce you to today's speaker, I'd like to share a little bit about a framework that unites ASHA's diverse membership. ASHA believes that schools have a responsibility to meet the needs of the whole child. The whole school, whole community, whole child, or WSCC model, developed jointly by the CDC and ASCD, provides a framework for the health and ed sectors at the state and local levels to work towards stronger alignment, integration, and collaboration. This approach puts the student in the center to ensure that all students are safe, healthy, engaged, supported, and challenged. This holistic and synergistic approach requires schools, students, families, and community partners to focus on improving both health and educational outcomes, and to create schools that nurture and support all students. It's a team effort, and collaboration is the key to success. A multidisciplinary approach that involves school nurses, counselors, health educators, physical educators, community experts, administrators, and students can better leverage resources and expertise to address the needs of the whole child, meeting the child's physical, emotional, social, and academic needs. Using the knowledge and wisdom of this school health team and research, schools can develop policies and programs that support all students, keep them safe from physical or emotional harm, and empower them to take responsibility for their health and well-being. In coordination with the CDC and the NACDD, we published a special issue of JOSH on the WSCC model that was published in November 2015. It's available via open access, and we'll provide this link to this issue in our follow-up email. All of ASHA's webinars tie back to this model, and today's topic of You Are the Key to Cancer Prevention is no exception. Today's session focuses on health services, family engagement, and health education sectors of our WSCC model. A couple of notes before we begin. Your phones will remain muted for the 60-minute duration of this webinar. If you have any questions, please type them in the questions box on the screen, and we'll try to address them at the end of the presentation. We are recording today's session, and we will send you a link to the recording, as well as the evaluation survey and slides within the next couple of days. All right, now let's get started with an introduction of Dr. Mary Koslap-Petraco. Dr. Mary Koslap-Petraco is a clinical assistant professor at Stony Brook University School of Nursing in Stony Brook, New York, and a primary care provider in her own private practice. She's also a nurse consultant on the staff of the Immunization Action Coalition, a nationally known expert in immunization practice, and has been an advisor for the Centers for Disease Control and Prevention and served on the National Vaccine Advisory Committee. Dr. Koslap-Petraco has advised local and state health departments on immunization public policies using her expertise as a public health nurse to influence system-level changes. She's the online advice nurse for parents of kids with infectious diseases and a member of the executive board of Every Child by Two. She's also a fellow of the American Association of Nurse Practitioners. Thank you, Dr. Koslap-Petraco, for leading today's webinar. I am now going to turn the controls over to you. Are you with us?
Yes, I am.
Okay, great.
Just changing screens, and thank you very much for having me today. I'm really so happy to be here with all of you. Okay, I think we're good. Everybody can see the slides, I hope. Again, I'm thrilled to be here with all of you today, and I'm not going to review the objectives because I think you all have access to those, and I really want to get into the real meat and potatoes of what we're going to be speaking with today. So we're just going to move forward, and our topic today is HPV. This is a subject that's very near and dear to my heart because it's affected members of my own family as well as patients that I've cared for over the years. This is a nice picture of the different types of HIV and their disease associations. You know, everybody thinks, oh, HIV is just one thing, but it can be several different diseases, and I hope we're going to be able to, that one is one of our take-home messages for today. 16 and 18 are the two strains that are the most commonly known to cause cancers in human persons. So we're going to kind of focus a little bit about them today, but you don't want any kind of HPV, and that's what part of my message is about vaccinations. All right, so what's the infection? Most males and females are going to be infected at some point in their lifetimes throughout the United States. I mean, those statistics are really daunting. 79 million Americans are currently infected. We get 14 million new infections every year, and it's the most common in people in their most commonly seen in people in their teens and early 20s. Most folks don't even know that they have it until, God forbid, you come down with one of these terrible cancers that's related to this infection. Every year in the United States, 27,000 people are diagnosed. That's one case every 20 minutes. These are the cancers that are caused by HPV. And if you see there, cancer of the anus, the cervix, oral pharynx, penis, vagina, vulva, just look at that data with the oral pharyngeal cancer. Honestly, if we can get everybody vaccinated, we can virtually eliminate head and neck cancers in the United States. These are the newer cancers caused by HPV per year in the United States between 2006 and 2010. And you will notice there that in women, the most common is cervical cancer, and in the men, most commonly is oral pharyngeal cancer. Just recently, a family member of ours, a male family member, was diagnosed with oral pharyngeal cancer in his early 40s, and he was probably infected when he was a teenager. This is the annual report to the nation on the states of cancer and HPV-associated cancers and some of the demographics and the numbers of oral cancer rate increases. 4.9 for Native American men, 3.9 for white men. I mean, I know you've probably heard some of the actors talking about the HPV diseases they've had themselves. Farrah Fawcett died from anal cancer related to HPV. So this is something that can touch everyone. The anal cancer rates have doubled since between 75 and 2009. And vulvar cancer rates has also risen dramatically. Penile cancer rates, while not as large as some of these other numbers, have also increased, especially among Asian men. Cervical cancer, of course, is the thing that the one cancer that I think most people are concerned about, and these numbers are really just dramatic. 500,000 plus new cases, plus 275,000 attributable deaths worldwide. You know, I don't want you to think we're just thinking of the United States when we talk about these diseases, because when I first heard about this disease and we started talking about vaccine, one of my concerns was that this vaccination would be available to women throughout the world. And thankfully, the drug companies have decided to do that. This vaccine is available in developing countries, and it's as far as the finances are concerned, there are different groups that are paying for this vaccine so that women, no matter where they are, can take advantage of this. Quite honestly, in the United States, if you go for your regular pap smears or if you're seen by a healthcare provider, you've got a decent chance of this being picked up before you die. But there's so many other complications to this disease. I think that's what really makes it such a tragedy. But if you're in a developing country, you might not even know about it until it's far too late, and it's really just an awful death where women rot from the inside out. 37% of the cervical cancers occur in women who are between the ages of 20 and 44. That's our childbearing years. So this is really something that we really need to address. These are the rates of cervical cancer by race and ethnicity. And if you notice there, some of our minority groups have a higher incidence of these illnesses. So all the more reason to reach out to them and make them feel comfortable about vaccinating their children. Cervical precancers in the United States, these are the things that are picked up on pap smears. There's 1.4 million new cases of low-grade cervical dysplasia. And once you have this cervical dysplasia, that means people are going to start poking at the cervix. And every time you poke at the cervix, that decreases the chance of ultimately having a successful pregnancy because it weakens the os or the opening of the cervix. This is a really nice poster that we use in the HPV campaign. HPV vaccine is cancer prevention, and that's what we always want to talk about. We want to prevent this before any infection gets started, and talking about children between 11 and 12 years of age. And that's not just healthcare providers, that's parents as well as healthcare providers. But I think the school is a unique place in order to be able to have contact with both the parents and the children to emphasize the importance of this vaccine. So we have these great vaccines now. There's a recombinant L1 capsid protein that's a virus-like particle, and that's just a picture of it there. Actually, it's kind of pretty. Too bad it's such a deadly virus. But then there's also the non-infectious and the non-oncogenic viruses. And what these do is they produce a higher level of neutralizing antibody than the natural infection. So that means they've managed to weaken this genetic profile that's going to fool the body into thinking they were infected and to set up the immune response. So these are the recommendations. Girls and boys can start vaccination as young as 10 years of age. Preteens should finish their vaccine series by their 13th birthday. And we do have really good data that shows the younger we give this vaccine, the better it works. We may give this vaccine as late as 26 years of age if they've never started this series in the past. And the reason that we stop at 26 is because that's where the studies were done. And the data shows us that most people in the United States have been infected by HPV virus by the time they're 26 years of age. For the boys, we can go up to 21 years of age if they've never had the vaccine before. And quite honestly, just vaccinating the girls is certainly not going to do it. We found that out when we just tried to vaccinate people who were high risk for hepatitis B. It really did not bring the numbers down until we started vaccinating everybody. So routine vaccination is 11 to 12 years of age. But again, you can give it as young as 10 years of age based on the latest CDC recommendations. We can give it up to 26 years of age for females and 21 for males not previously vaccinated. It's especially important to get the vaccine into men who have sex with men or immune compromised individuals, including people who have HIV infections, because we want to boost their immune systems as much as we possibly can. There is more than one formulation, but just within the last week or couple of weeks, the HPV-2 formulation has been withdrawn from the American market. So children as young as 9 years of age, as I mentioned before, can routinely receive the vaccine. All children, in my opinion, should get it. My children got it when they were younger, and my daughters-in-law tell me as soon as my grandchildren are old enough, they plan on getting this vaccine for them. The big issue is we want to make sure we vaccinate before sexual debut. So what is the schedule? It's 0, 1 to 2 months, and 6 months, generally speaking. But if children start the vaccine series before the 15th birthday, they only need 2 doses and given at 0 and 6 months. This is a tremendous advantage. First of all, it cuts down on the number of visits. Second reason that we do that is because it does hurt. That's the one big drawback to the vaccine, and you have to warn the children and the parents that this vaccine does hurt when you give it. So it's one less dose that we need to give. Now, if you don't know what they've had previously, you're always, because there are children still in the United States who've had anywhere from the 4-valent to the 9-valent to the 2-valent. You're just going to pick up where you gave off. If you don't know what they've had previously, then you're going to give the 3 doses. So HPV-9 is administered generally in a 3-dose series. The interval between the first and second dose is 1 to 2 months, and the interval between the second and third is usually 4 months. That's the minimum, but you want to make sure you have 6 months between the first and the third doses. This is kind of hard to remember. Excuse me. But if you give this regularly, or you can put these little cheat sheets in your pocket, that's a perfectly acceptable thing to do. In fact, this isn't a bad place to give a plug for the CDC's app that you can put right on your telephone that will give you the vaccine schedule, and then when you're looking for something, you just pull it right up on your phone. And that, please note there that if the vaccine the schedule is interrupted, you do not need to restart. You just pick up where you left off, and that would be age dependent. Of course, vaccine safety is extremely important, and we want to talk about that. We always want to weigh the safety versus associated risk. So the HPV vaccine safety monitoring really has a very, very good profile. I'm sure all of you heard some of the scare stories that have been put out there by the anti-vax people about this vaccine causing all these terrible things, from multiple sclerosis to infections to generalized immune deficiency responses, none of which have been backed up by the research. So among 7.6% of the reports that were coded as serious, the most common things that we've seen is headache, nausea, vomiting, and fever, and fainting. Adolescents are unique individuals. They don't eat regularly, and they don't want to let you know that they're scared about something. So make sure you have your adolescent seated in the chair, because like I mentioned, this vaccine hurts. You pinch them with that vaccine and they haven't eaten and they're a little dehydrated, they may very well have that syncopal episode. So these are some of the things that you want to talk to the adolescents about, or if the children are coming in, remind the parents to make sure that the children eat beforehand. We always used to keep food and like crackers and something to drink for the children when they came in, just to make sure that they had something when we were giving this vaccine. So the key findings were, and these are some of the things I mentioned before, venous thromboembolism. They found no increased risk of VTE following the HPV-4 vaccine. Those autoimmune disorders, no association between the vaccine and these 16 autoimmune disorders that they studied. Injection reactions and syncope, there were no major safety concerns noted, but these were the things that we saw most commonly: the sore red arm and the syncope. I always tell my patients and my parents, make sure as soon as you get home, you put a nice cool washcloth on that site where they got the shot, and that definitely does decrease the redness, swelling, and discomfort in the area. So this is a little bit more about the IOM review on syncope and anaphylaxis. They reviewed the association between 8 vaccines and the possible side effects. So it did favor acceptance of a causal relationship. Evidence favored causal acceptance of the causal relationship between HPV and anaphylaxis, which is one of the things that they studied, and they found this was very rare. Another question they had was, convincingly supports a causal relationship between injection and the vaccine and syncope. That was supported. And honestly, in my own practice, that's what I saw as well. There was not enough evidence to find a causal relationship between HPV and the other specific health events that they studied. There were 7 pre-licensure studies done, including 15 with males and females, and the vaccine was generally well tolerated. The biggest issue with this vaccine is it hurts and it can cause the sore red arm. The adverse events were very similar to what they had seen in the HPV-4, but they did see more injection site reactions among those who had the HPV-9 than the HPV-4. And again, the big key to this is talking to parents, telling them that this can happen, and telling them that this is not a side effect, but this is an expected reaction to the vaccine. I always tell parents, you know, when they get that sore red arm, that means their immune system is working and they're mounting a good immune response to that vaccine. I just had to do that a couple weeks ago with my babysitter who called, and she was all upset because her child had a sore red leg and nobody told her that could happen. And I said to her, if I told you that could happen before you saw that, how would you feel? She said, I certainly would have felt a lot more comfortable and I wouldn't have panicked. All right, so this is a really good slide. This is the presence of HPV disease before and after introduction of vaccine in the United States. Now, if you look here, even with only 1 or 2 doses, we have already seen a decline in the age group that's been vaccinated in the number of cases of HPV over time. So this is the Australian study. In Australia, HPV vaccine is mandatory. And if you look at this slide, this clearly indicates when you get the 3 doses into the children, there is a dramatic drop in the number of HPV cases following receipt of this vaccine. They did a systematic review and a meta-analysis at the population level, and there were 20 studies in 9 high-income countries. And in the countries which had over 50% coverage, and Australia was one of them, they saw at least a 68% decrease in the number of new cases. And the anal warts decreased by 61%. And there does seem to be some evidence of herd immunity. So how long does this vaccine last? Well, we have studies now that are showing that this protection is long-lasting. We know that the studies are at least 10 years old, and we have evidence clearly indicating that the immune response is still at a great level after the 10 years. And they're going to continue to study this out from year to year. Now, this is our message. The vaccine is safe, it works, and it lasts. So this is adolescent vaccination coverage in the United States between 2006 and 2014. And we're really doing a pretty good job with our other vaccines, but look where the HPV vaccine is. It's really at the bottom of the barrel, and we need to change this. Now, we talk about missed opportunities all the time. Just earlier this morning, I was listening to the latest session in the Pink Book course for my friends and colleagues at the CDC. And this was one of their big take-home messages. What we could do if we eliminate the missed opportunities. And by missed opportunities, what we mean is that children come to the office for something else, not necessarily a vaccine, and we don't even review their immunization record or bring up the fact that they still need another vaccine. It doesn't matter what they come in for. Their school physicals, their sports physicals, their working papers, they have a sore throat. Review those shot records, because if they're not seriously ill, they really should get another dose. And look at the dramatic increase when we would do something like that. You can go from 47 to 91%. They did another study that looked at why parents don't start the HPV vaccine for their children. Excuse me. The biggest reason was we as providers weren't recommending it. And honestly, I can back that up, having done many a post-assessment visit when I worked for a local health department. Providers said, well, I think it's too early. I don't think we need it. I haven't seen any. So they weren't recommending it. And we do have really good data that shows when providers recommend something, parents are far more likely to get that vaccine. Now, look at those. These are values that parents place on the vaccinations themselves. They place a pretty high a score on the HPV vaccine, but we as providers aren't really doing our job when we don't recommend it appropriately. Okay. So these are the estimations, and this is how we underestimate whether the parent really wants to get the vaccine or not. Okay, so there's perceived concerns on the part of us as providers about whether or not the parents want the vaccine, but the real concerns are whether or not we do recommend them. All right. So we want to give that effective recommendation at HPV vaccine for HPV vaccine at ages 11 or even younger, because as I mentioned earlier, it's not too soon to start it at age 10 years of age. Many of the mothers, when they asked them, said if the physician or the healthcare provider had spoken to them about the vaccine, they would have given it, which is a big difference from the providers telling me, oh, parents don't want it. So again, we have to rethink our behavior. So we want to make that effective recommendation. Recommend the vaccine the same way that you would the Tdap and meningococcal vaccines. When I recommend the vaccines to my adolescent patients, I say, I want to give your child a vaccine that prevents whooping cough, one that prevents meningitis, and one that prevents cancer, and bundle them all the same way when I'm discussing them. And I want to give them all today. Your child's immune system is in great shape and is well capable of setting up a good immune response to all of these vaccines we're going to give today. And there's my picture of the bundle together. All right, Sophia's 11, and she's due for 3 vaccines. These will protect her from meningitis, HPV cancers, and pertussis. We'll give her those shots at the end of this visit. That's an example of a good way to talk to parents and explain and tell them what you want to give today. Most of my parents just say, fine, I'm ready. Some parents might be interested and have some more questions, and again, you are the person to reassure them about the vaccines and ask them if they do, what is their main concern, and make sure that you're addressing their real concern. If they say, well, I don't want that HPV vaccine, ask them, well, what is your concern about that vaccine today? How can I help you and give you more information? Always with a smile on your face, too. Why does my child need HPV? I'm recommending it because that your child needs to start this vaccine today because this vaccine prevents cancer. What cancers are caused by HPV infection? Well, there's certain times that can cause cancers of the cervix, vagina, vulva in girls. It can cause cancer of the penis in men, and cancer of the anus in both men and women. It can also help to prevent. It is also good for preventing head and neck cancers. That's why it's important for me as your healthcare provider to make sure that I give those vaccines to your child today. Is my child really at risk for HPV? It's a very common virus, and we can help protect your child against these the cancers caused by these viruses by starting that HPV vaccine today. Why do you want to give it so young? My child's only 11 years old. When should the bike helmet go on? Right away, right? If we don't put the bike helmet on, it doesn't protect. So if we don't put the HPV on, by the time the children get older and start having sex, we're not going to have it on board for them. Boys and girls can start HPV as young as 10 years of age. Preteens should finish by the 13th birthday. Okay? Once they're 26 years of age, it's too late for them. Once they're 21 years of age, it's too late. Please offer them this life-saving vaccine. This kind of goes back to what we were just talking about before about the clinicians waiting too long to make that strong recommendation for HPV. And actually, it's the male physicians who the data shows are most reticent about speaking with about this vaccine and offering this vaccine to the younger adolescents. So I think we need to think about that. HPV vaccine works best at the recommended ages. That's why I'd like to start your son to start the series today. And then also remind the parents, the younger we give this vaccine, the better it actually invokes the immune response. That was the basis of changing to the 2-dose series for children less than 15, because we saw such a robust immune response in this age group. The data showed that we didn't have to give the 3rd dose. I have some concerns about the safety of the vaccine. I keep reading things online that say HPV vaccine isn't safe. Do you really know if it's safe? I know there are stories in med and online, and I can see that it's of concern to you. I'm concerned myself, but I know that HPV vaccine has been carefully studied for many years by medical and scientific experts. And based on all of that data, I truly believe that HPV vaccine is very safe. And if you have a personal story about the HPV vaccine, if you got it yourself, or if one of your children or grandchildren received it, tell that parent that they received the vaccine, because that really helps them. Vaccines, like any medication, can cause side effects. With HPV vaccination, this includes pain, swelling, or redness. Sometimes children faint when they get shots, and they could be injured if they fall from fainting. But we're going to protect your child by having them stay seated after the shot. Please make sure you tell parents this vaccine can cause redness and swelling, and it hurts when we give it. I asked my dear friend and colleague, Dr. Koslap, why this vaccine hurts so much compared to some of the others we give. And he said that the vehicle that we make this that the vaccine is made in is pure salt. So he said, think about taking a syringe full of pure salt and squirting it in somebody's arm. He said that's why it hurts, and that's where the pain comes from. Could HPV vaccine cause my child to have problems with infertility? We have no data to suggest HPV vaccine will have an effect on future fertility. However, women who develop cervical cancer could require treatment that would limit their ability to have children. Remember what I said to you when we started the talk, that if they have these cervical changes, that they're going to want to start doing interventions to get rid of the cervical changes on that cervix. And once you start poking at that cervix and doing testing and treatment, that decreases the cervix's ability to stay closed and to ultimately carry a child to term. So, I mean, the way the slides are written, you certainly can take this message and rewrite that message in your head so that it comes across in a comfortable way for you when you're speaking with the parents. These are really examples for you. I'm just worried that my child will perceive this as a way to a green light to have sex. We've done lots of studies that show getting the vaccine does not make children more likely to start sex any earlier than they would if they didn't get the vaccine. So starting this series today is the best possible shot at protecting your child for the future. How do you know if this vaccine even works? Well, we have all these studies that I mentioned to you before that you can point out to parents, telling them that HPV vaccination works very well and has decreased not just cervical precancers in young children, but genital warts as well. So the earlier we start these series, it's the best protection possible. Why do boys need the vaccine? They don't get cervical cancer. Okay. HPV vaccine can cause cancers of the penis, the anus, and the throat in men, and also can cause genital warts. Getting your vaccine today for your son can help prevent these infections in your son that could lead to these diseases. And I mentioned to you earlier, a male family member of ours just recently had cancer of the tonsil related to HPV. Would you get this vaccine for your kids? Well, you bet I would, okay? I've given HPV vaccine to my own children, and I believe it's important in cancer prevention, because I can say that because I did. I mean, I can also tell them that my grandmother died in 1955 from cervical cancer, and I don't want my patients' children to face those kinds of issues that we've seen in my own family. If you have those family stories, share them. The American Academy of Pediatrics and the American Academy of Family Physicians, the National Institute of Health, and the CDC all agree that getting this vaccine is extremely important for your child. I heard there's a new HPV vaccine that works better. Should I be getting that for my child who already finished the series? Currently, and the answer to this one is, well, right now we don't have a recommendation to vaccinate with the 9-valent vaccine if they finished the either the 2-valent or the 4-valent vaccine, because those other vaccines cover the most common types of cancer that are available. So right now the answer to that is no, and I feel comfortable about saying that based on what we see in the data. When do we need to come back? Okay, your child needs a second dose in 1 to 2 months, and the third dose will be due 6 months from today. When you check out, please to make sure you make the appointment for about 6 weeks from now and then 6 months from now, and you'll have those appointments on your calendar. And honestly, there's a lot of things available to practices. You can put things on text messaging that's going to send a text message. There's even one that we even have another study that shows if you send a text message to the adolescent and previously received parents' permission for that, that's an even better way to remind the family to come back for those subsequent doses of vaccine. Okay, if the parent doesn't say yes, you want to clarify, restate their concerns, emphasize that it's the parent's decision, acknowledge the risks and conflicts, and applaud them for wanting to know what's best for their children. But be clear that you're concerned for the health of their children, not just public health safety. And then advise the parent, make sure that you understood their question and you're answering it accurately. Allow that time for discussion. Be willing to discuss their ideas and offer the written resources. Send the VIS home. CDC has some great pieces on their website, very colorful, very helpful, informative pieces that you can give the parent to take home. And tailoring your advice using the presentation that we're doing today. So in response to a parent supportive of vaccination but with HPV concerns, instead of actually studies show there is a serious side effect from the vaccines. So I think you should there are no serious side effects from the vaccines. So I think you should let your daughter get it. It's really important. You should say something like this. It sounds like you're really supportive of vaccines, but you have some concerns. Is that right? So if you had information that convinced you the HPV vaccine was safe, why don't you consider letting your daughter have it? Just recently, I gave this same talk to a group of nurses, and one of the nurses came to me after the talk and said to me, "You've changed my mind about the vaccine." She said, "I went to my private provider, and he just said, I want to give this HPV vaccine, and didn't explain anything, and I said, no." She said, "But after listening to what you have to say, I'm going to call him up and say, I got more information, and now I want to give that vaccine." So if the parent declines, declination is not final. The conversation can always be revisited. End the conversation with one action you agree on. Say, here's some literature that you're going to take home. And also remind them, well, the next time you come back, I'm also going to ask you if you need more information to change the decision that you've made for your child. And you want to remind them that waiting to vaccinate is a risky choice. Some pediatricians do ask parents to sign declination forms. So here are some of the resources that I mentioned to you. The CDC website is right there for you, and it's very easy to find, and you can just point and click. The Immunization Action Coalition also has some really excellent education pieces for HPV. The materials that I'm showing you today are directly from my colleagues at the CDC. Okay, so HPV vaccine is cancer prevention. You are the key. We can stop this disease from occurring simply by how you present this to parents, how you the attitudes that we have, and clearing up so many misconceptions. We've all heard about all of those horrible stories about things that are being shared on the internet, and stories that are being told about my child had the vaccine and a day later they weren't able to stand up and talk and walk. I mean, I know there's pictures on the internet of children with ataxia that parents are claiming was related to the vaccine, but when these cases were fully investigated, there was no connection to the vaccine. I do know that one child that was circulated for quite some time on the internet was, she had this ataxic walk and she was shaking. That was a conversion reaction. So once they got some mental health counseling for this child, her symptoms began to resolve. Again, we have to be assertive, positive, speak to parents clearly. Please do not talk down to them. I've heard parents say to me, oh, my provider was really upset with me because I refused to vaccinate. Passion is one thing, but kindness and consideration goes such a long way when you're discussing these issues with parents. You want to always smile, you want to be upbeat, you want to give parents the opportunity to ask those questions. Just recently, someone asked me, well, what's the difference between the way nurses and nurse practitioners discuss issues and the way physicians discuss issues? And I think I've pointed some of those out today about being that kind of provider, whether you're a nurse, physician, nurse practitioner, PA, nursing assistant, school teacher, whomever you are, having that empathy in your voice, listening clearly to what the parent has to say, and making sure that you don't miss something that's extremely important that the parent may be subtly saying to you. Warning them about how sore it makes the children's arms. A lot of times I've warned the parent, oh, they're going to have a terribly sore arm the next day, but I'd rather have a sore arm than have cancer. And then they'll come back to me for the next shot and say, well, gee, it wasn't as bad as you told me it was going to be. So that kind of makes me feel good that at least I'm warning them and they won't be frightened if the child does get a red sore arm. As far as fainting is concerned, warn them, and make sure you keep that child within your vision for at least 20 minutes following the vaccine. Little children cry all the time after they get their vaccines, and that's a wonderful thing because they get all of their fear and their anxiety out through crying. Adolescents don't cry, especially the big boys. I mean, most of my fainting that I've seen when I give the vaccine is the big football player boys who are these big brave boys, and they're not going to cry, and they're going to sit there and they hold their breath, they don't eat, they're sitting in my chair, and before I see it, their eyes are starting to flutter, and we put them right down on a bed to lay them flat to resolve that syncopal episode that they're having. So it doesn't matter whether they're big children, little children, please, please, please make sure they're all seated. We do have one instance of a death following the HPV vaccination secondary to the adolescent hitting their head on the ceramic tile floors and developing a hematoma. So that was the one and only one. So if there's things that the anti-vax community has worked that up and used that to their own devices, it wasn't the vaccine. It was because the child fainted and fell and hit their head. I don't ever want any of you to have to go through something like that. So the big, 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 big thing is making sure that those children are seated and they remain seated for 20 minutes following giving the vaccine. We've had a couple of children, and we always use the vaccine questionnaire before we give any of our vaccines to make sure that we don't have an allergy or some other reason for withholding any or all vaccines for a specific child. And then we sit the child in the chair and we give the vaccines, and all of a sudden the child develops syncope. And that's when the mother will say, oh, that happens every time he gets a shot. Oh, dear. So that's why don't ever think that you've gotten all of the answers from the parents about fainting before the child gets the vaccine. A lot of times the adolescent is embarrassed and doesn't want to let you know that they fainted in the past. So just please keep those things in mind. And I think I have come to the end of our talk for today, but I am really happy to answer any questions that you may have on any of the issues that we've gone over. But I think the take-home message for today is the HPV vaccine is safe, it's effective, and it works. And if you want to use my stories about my family, about our male family member who had tonsillar cancer, if you want to talk about my grandmother who died in 1955 from cervical cancer, please do so if you don't have any personal stories for yourself. Because quite honestly, when you put a personal spin on what you're talking about, it really means something to families. It's not just something that you're talking about that you picked up out of just the data or just what would be like a canned speech. it really personalizes for the parents, and it makes them feel that you have a personal stake in wanting to protect their children. And I think if there are questions.
Okay, great. Thank you so much, Dr. KP. This is Lee Lowry again. We do have, well, at this time, because we have about 15 minutes left in the hour, I want to encourage folks to go ahead and submit their questions. We have another 15 minutes to address them. So please go ahead and send them in. And we'll start with the first one that we have here, which is, this came in pretty shortly after you started from an audience member who says that the ACIP recommendations have changed as of last fall, 2016, regarding a change to the number of doses for children before age 15. Can you speak to that at all?
Yes, I think we covered that. You know, I started out with the 3-dose series because that was what we began with, and then I did cover the 2-dose series. Absolutely. Last fall, and then it was published in the MMWR. If we start the series before age 15, then it's only 2 doses, and it's separated by 6 months. And I think I talked about some of the advantages of this schedule.
Because it hurts.
Mm-hmm. It hurts, and it's only 2 visits instead of 3. So yes, and when the participants get the slide deck, they will see that information covered in the slide deck.
Okay,
so
great.
Great.
Thank you. You did, yes. Okay, the next question is, what common questions have you gotten from the children?
The children, honestly, the children are really great. They have a lot of questions about cancer, quite honestly. They want to know what cervical cancer is. So I've gotten that a lot from the girls. The boys, they want to know about cancer of the penis. The girls, when I explain to them what cervical cancer is, I tell them that it's they can get cancer of the bottom part of their uterus or womb, which is where the baby would be born through, and there's a nice tight closure there. And if they get cancer there, then the kind of treatments that they have to do is kind of poking into that, and it softens that nice tight muscle. And when that nice tight muscle becomes soft, the baby, the pregnancy won't stay inside the uterus where it belongs. That's probably one of the most common questions from the girls. The boys, when I talk to them, in fact, I've had hesitant mothers about giving the vaccine to boys, and then in the course of explaining to the boys, as well as the parent, about what cancers that this vaccine prevents, I tell them it prevents cancers of the cervix in the girls, and cancers of the penis in boys, and cancer of the anus in both boys and girls, and the throat cancer. And as soon as I say cancers of the penis, that's when I get the questions from the boys. And they will ask me, well, what would happen if they had cancer of the penis? And I said, I have to be honest with you. You will have some type of surgery. That's probably like the most common question from the boys. The boys have also asked head and neck questions about the tonsillar cancers, and I do tell them, that is like if they're having oral sex, that they can be at risk for head and neck cancers related to this virus.
Okay, great. Good answer. Good question.
Yes, that's a great question.
Okay, here's another one. Can you clarify, okay, I think you have, but we'll do it again. Clarify the recommendation. Is it 2 or 3 doses of vaccine?
It's 2 for under 15, separated by 6 months. And once they're 16 or older, then they have to have the full 3-dose series. That's given at 0, 1 to 2 months, and the third one is given 6 months after the first dose.
Okay, so a follow-up question, this is coming from me, is so if you go with the 2 doses, do they both have to be completed before the age of 15?
Yes, they do. They must, and if they get if the second one, if suppose the child comes to you, they've had one at say 14 years old, which is really not good because it was late, but at least they got 1 dose. But now you have a 16-year-old sitting in front of you. You're going to give dose number 2 today, and then in 3 months you're going to bring the child back for the 3rd dose, because you have to have at least actually you could bring them back in 2 months, because you have to have at least 6 months between the 1st and the 3rd dose, but you have to have at least 2 months between the 2nd and 3rd.
Okay. Here's another question. Any activity suggestions for the classroom with students?
Oh, that's a great question. Honestly, if you go to CDC's website and pull up some of those nice pieces that they have there, they're really in color. You could bring use those for a classroom activity, such as talking about maybe you could learn name the activity. How can we prevent cancers? And then use the CDC pieces about preventing cancer. Because I mean, honestly, this vaccine prevents a lot of cancer. We have another cancer prevention vaccine, and that's the hepatitis B vaccine. But that vaccine only prevents liver cancer. This one prevents cervical cancer, vulvar cancer, head and neck cancers, cancer of the penis, cancer of the anus. That is an enormous amount of protection from just one vaccine series.
Great. And this is a good question to follow on. Can the HPV vaccine prevent genital warts or just cancer?
The HPV vaccine does prevent the genital warts from the strains that are contained in the vaccine. So we have seen a really huge decrease in the number of people coming down with the warts. I mean, they're not going to kill you, but they sure are unsightly and they're not pleasant to have removed.
Okay. If a young adult states that they have not been sexually active and have not received the vaccine, can they get it at age 26 or older?
26 is the cutoff. They have to be, finished by 26. I guess the better way to state that is by the 27th birthday they have to be finished. And the reason for that is it's not that the vaccine won't work. It's because when the CDC made this recommendation, it was because the vaccine was tested in this age group, and their data showed that by age 26, almost everybody had become infected. I mean, I will tell you that there are providers who will give the vaccine what we consider off-label, which means after age 26 to someone who would be like that, but then the insurance would not pay for it. The individual would have to pay on their own. Because honestly, I've heard this discussion among the gynecologists who have women who have not been sexually active because they've been in monogamous relationships for years and suddenly find themselves single and then wind up in the office of the OBGYN with a positive HPV because they don't think they can get pregnant any longer, so they're not using protection. So, like I said, I know there are providers who will give this off-label, but I can't recommend that because that's not the CDC recommendation.
Okay. This person states that they have read that if... Okay, yeah, we've already said this. Okay, this person states that they've read that if the child starts the series before age 15, they only need 2 doses regardless of age.
No, they have to finish it by 15.
Okay. Alrighty, let's see.
And the reason, I think if I give a reason that's a better answer.
Okay.
The reason why they have to finish it by 15 is because the data clearly indicated the immune response was so robust. If they finished it before 15, they didn't need the third one. Once they're 15, they get past that, the 16th birthday, the immune response is not going to be as robust. So therefore, they need the 3 doses.
Okay. This person's asking if irregular pap smears are related to HPV. This person's a high school teacher, and their gynecologist said often it is related. Can you add any more to that response?
Yeah, honestly, that is the most common reason for an abnormal pap smear, is related to what we call CIN or SIN1 changes related to HPV. They see these small small changes in these cells on the cervix, and those are the precursors to the HPV cancers, and that is one of the most common reasons for having an abnormal pap. And it's because those little, it's in the slide deck there. I didn't spend a whole lot of time because, like I said, I wanted to make sure I left enough time for questions. But in the slide deck, you'll see there, it's called the CIN1 changes, or what are seen in those pap smears when there has been an HPV infection that has gone on to cause the cervical changes. Because on the other side of the coin, most people, excuse me, with robust immune systems will shed the virus on their own. They could be infected, but they will never come down with disease because their immune system kicks into high gear and sheds it on their own. But we don't know if you or the next person or me or my sister or my cousin or my nephew is going to be the one who's going to shed the virus. Therefore, we need to vaccinate everybody.
Okay, great. Here's an interesting question. So have you ever experienced a child wanting to be vaccinated, but their parent does not consent?
I'm sorry?
Have you ever experienced a child wishing to be vaccinated, but the parent not wanting to consent? What happens in that situation?
Yes, I have. Because culturally, there are some cultures that I have worked with that are not real, that are really very hesitant about this vaccine. And then when I start explaining why I want to give the vaccine and what the, what this is going to prevent, and then of course I do tell them that it hurts, and and it's okay to cry, and we're going to have you sit down. And I've had children turn around and say, "Mom, sign on that paper. I want the vaccine."
Mm-hmm. And then what happens? Have you had the parent say, "No, we're not going to do it," or?
No, honestly, the parent did sign. And that's more common with the boys than the girls, because once I start explaining about the head and neck cancers and the kinds of cancers the boys can get, I mean, the look on their face is like aghast. They're like, "Oh my God, I don't want that." And they're like, "Ma, I'll take the vaccine. Just sign the paper." And I've yet to have a mother refuse to sign when the child says, "I want it."
Right. That's so interesting. Okay, how about this one?
A lot of times the parents have come from another country, and there's cultural taboos and cultural issues. And the big one is related to, a lot of times, well, is this going to make my child want to be sexually active at a younger age? Which we know the data clearly indicates is not true. But with the children are educated here in the United States and very often have a different outlook than the parent does. So a lot of times it's the child helping me to educate the parent.
Right. Okay, we have another question. Where can teens get the vaccine besides their family provider? Is there any other places they can go?
Well, it depends on what state they live in. But they can go, a lot of states, the pharmacy will give the vaccine, but it depends on what state you live in. But if the teen is not 18 years of age, they would have to have the parent go with them to sign. And then there are public health clinics that are available if there's a financial issue with the families. There are school health clinics that provide the vaccine. So I guess that would be the other places where they could go. I mean, and then they have, sometimes they'll have like a big campaign. They might have a health fair or something where vaccines would be offered. But again, if they're not 18 years of age, they would have to have the parents not so much sign a paper, but at least verbally agree that the child can be vaccinated.
Okay. Can you talk a little bit about the pain that this causes and what it's like and the duration? Is it something that's lasts for a couple of days, or is it just the 10 minutes? And how severe is it?
It's usually 24 to 48 hours. It's usually the worst within the first few hours, and it's usually I don't think I've ever seen it last more than 3 days. And as time goes on, it gets less and less. But I tell the children, it's going to feel like I punched you in the arm tomorrow. So when you go home, get cold water on a washcloth and put that right on your arm, and just keep, putting that on for about 10, 15 minutes every hour or so, and that will really make it much more comfortable for you.
Okay. And is there any medicine that's recommended with that?
Well, if they're really so sore that they really can't stand the pain at all, yes, they could take Tylenol or Motrin. But quite honestly, I can't tell you how many doses of this vaccine I've given, and not one has had to go as far as taking Tylenol or Motrin.
Okay. All right, well, that concludes our questions, and it's perfect because we're right at the end of the hour. And so I just want to take this moment to thank you, Dr. KP. This was a great presentation. We had a very active audience with lots of questions and interaction, so thank you so much. And I just want to remind everyone that we will be sharing an email in the next couple of days that will include these slides, that will include our evaluation for folks who are pursuing continuing education credits. We'll have a link to the recording that you can share with others, and probably some links to other resources as well that we've discussed today. So you can look for that. And again, thank you so much, Dr. KP.
Well, thank you so much for inviting me and giving me the opportunity to meet with all of the participants today.
Wonderful. Thank you. Okay, at this time, we're going to end the webinar. Thank you, everyone. Bye-bye.
Bye.